Hello, everyone, and thank you for attending today's webinar, Addressing Patient Misidentification, Soothing the IT Pain Points, and Mitigating Safety Concerns, which is sponsored by Imprivata. I'm Evan Sweeney. I'm the Executive Editor with Fierce Healthcare, and I'll be moderating this webinar. I'm really excited about our speakers today who happen to know a lot about the issue we're going to be talking about. First up is Ben Moskovich. He's the Project Director of Health Technology at the Pew Charitable Trust. And next up we have Zach Hedinger. He's the Medical Director at MedStar National Center for Human Factors in Healthcare. You can read their full bios on the right side of your window. A few technical notes before we begin. If you'd like to download the slide deck, please click the Resources List button at the bottom of your screen. The webcast is being streamed through your computer, so there's no dial-in number. For the best audio quality, please make sure your volume is up. You can find additional answers to some common technical issues located in the Help button at the bottom of your screen. The webinar is being recorded and it will be available on demand within 24 hours after the event. We'll follow the presentations with a Q&A session. Please feel free to submit your questions using the Q&A button on the left side of your screen. I think that's it. So Ben, when you're ready, please go ahead.
Great. Well, thank you very much, Evan and Sandra and the rest of the Fierce Healthcare team for inviting Pew to participate and for everyone for listening. For those that don't know Pew, we're a large nonprofit organization that conducts research and policy work on a wide range of areas, including on health IT, where our perspective and our research has shown that that electronic health records have tremendous promise to improve care and that additional steps are needed in order to realize that full potential. And one area that we've focused on is interoperability, and specifically the patient matching challenge within interoperability. So patient matching, when we talk about patient matching, we're referring to both associating an individual that shows up at a healthcare facility with their health record, but also linking records for the same individual when those records are held in different healthcare organizations, and where the patient, for example, wants their records to be linked to improve care coordination. Match rates can vary dramatically within organizations. Match rates up to 1 in 5 records may not be associated with a patient when they seek care, and those match rates decrease when talking about matching between organizations, where some research has shown that up to half the time records for the same patient are not linked or associated with one another. This has both safety and cost implications. On safety, one survey found that that within the last year, a patient had been harmed by a patient matching error within an organization. And the costs are clear when just talking about the staff and processes needed to fix an incorrect match. The cost can be up to $1,200, and that's not factoring in other costs as well, such as around duplicate lab tests or adverse events or safety events that occur because records are not effectively matched. There are several reasons why matching problems occur. One is that typos can be introduced into the record, for example, a patient's name or birthday misspelled. Another is that patients have similar information. They may share a home with a family member where they have the same address, or twins have the same birthday, things of that nature. Information could be missing. An address may not be included for a patient. A birthday might not be added, or a generic birthday might not be included. That's not the actual person's birthday, and other factors. Patient information changes. We know patients move, and they'll have a new address, or they get married, and so their last name will change. All of that can affect patients' records being accurately matched. We also know that the way data are formatted or standardized in the record can have an effect on patient matching rates. So for example, if an address is structured as one field versus multiple fields in the record. And we also know that sometimes people use other individuals' information in order to obtain care, and that can introduce inaccuracies that complicate matching. At Pew, we conducted several different research projects to try to identify some solutions or strategies or policies that can help improve patient matching. First, we conducted focus groups with patients across the country to understand their perspectives on both the problem in general, but also some of the different solutions that could be used to address patient matching challenges. We also interviewed healthcare executives also across the country to understand their perspectives both on the challenge within their organization and also on some opportunities to make progress. We spoke with experts across different industries, both the technology side, the healthcare side, privacy side, and so forth. We also contracted several different research projects and examined the research that has already been conducted on patient matching to identify several potential opportunities to improve matching and the pros and downsides of each. And I'll run through some of those. First, at a high level, the focus groups from patients revealed that patients are generally unaware of challenges with patient matching, though many of the patients we spoke with had a personal experience with this problem. For example, one patient was confused with their father when they sought care. What we did see, though, is that patients generally expected this problem to be solved, and once they were informed of the problem, felt it should be solved urgently or quickly, and that was so that they could obtain better access to health data, so that they could obtain more comprehensive care. They viewed it as helping prevent medical errors, and that it would improve the security and privacy of their information if patient matching were more effectively addressed. We did see some modest differences across some of the different focus group populations, though the overall perspective of patients that we spoke with, again, viewed addressing patient matching as as something important that should be focused on. We also spoke with healthcare executives, and one thing we heard was that in general, there's the sense that patient matching within an organization has been sufficiently addressed or is on the way to being sufficiently addressed, whereas there still is a lot of patient matching challenges when exchanging records between different organizations. Generally, the executives we spoke to said that their match goal was to be greater than 99%, and that we heard investments of up to 9 FTEs to address matching challenges. We also heard that there's some diminishing returns in addressing patient matching, especially within the four walls of an institution, and so to warrant additional investments, a greater improvement in match rates was needed. So one of the opportunities we examined to improve patient matching was unique identifiers. And as many of you on the call may know, there is a congressional prohibition on the Department of Health and Human Services from finalizing a standard for a federal unique patient ID. We looked at several other options for a unique ID or identifiers that would be close to unique. One thing that we did learn was that implementing such a system would be costly, and that there may be more advanced solutions than assigning everyone a unique patient identifier. So we looked at several opportunities for unique IDs, including smart cards, numbers and pins, passwords, and some other solutions, including biometrics. And while biometrics aren't technically unique, once coupled with demographic information or other approaches, they could be close to unique. In terms of patients' perspectives on unique identifiers, the overwhelming number of patients that we spoke with had a preference for using biometrics, and that's in part because patients are becoming familiar with biometric use, having them on their smartphones, and going to some public places where, like airports, where biometrics are more regularly in use. There are some challenges, though, with biometric use. One of the challenges is around the template for biometrics, which is how the biometric is scanned and stored. Different manufacturers of biometric technology can use different templates, and so comparing that information can be a challenge, both within a certain type of biometric modality, like a iris scan, and then there are also challenges then comparing between different types of modalities. And then certainly there's a lot of privacy challenges that would need to be addressed if biometrics were to be used for matching. There are several options for biometrics to be used. Here are 4 options that we heard. I won't go into each of these in depth. There are certainly many other options for how biometrics could be used. One approach is to standardize part of that template. Another approach would be for the different manufacturers of biometric scanning technology to make their scanners available to other companies to be able to serve as a translator between the different templates, and certainly many other approaches. Also, there are questions on whether biometrics should be scanned at a device in a facility or on a patient's personal device like their smartphone. And these are things that would have to be addressed and worked through if biometrics were to be used for matching on a nationwide scale. The second approach that we looked into was a patient-led approach to matching. And what we mean by that is right now, matching is primarily done at the healthcare provider level and is the responsibility of the healthcare provider and any technology vendors that they have. We asked what would happen if you turned that paradigm on its head and had the patient more involved in having their records matched. To do that, we commissioned a report from the RAND Corporation, and they studied several different options for better involving the patient in matching. And that led them to a multi-phase solution to recommend for this approach. The first is for the patient to verify their phone number. So for example, a patient going to seek care would provide their mobile phone number at registration and would receive a text message as to confirm that they are now trying to seek care or are seeking care at this one organization. They would respond to it to confirm that this number is in fact associated with them and that no typos were entered into the phone number. Once that occurs, that data point could be used with a higher weight when trying to conduct matching, as opposed to right now where phone number is used, but there's no additional indication that that phone number has been verified and is in fact correct and associated with that patient. The second step in the RAND report is for patients to use various smartphone applications to pass information to the EHR. So for example, they could have an app on their phone where they enter their name, their date of birth, and even some potential identifiers like a driver's license, which would then be sent to the EHR. This would prevent typos at registration, allow the patient to update their information, and allow the patient to enter any additional more unique data elements into their phone that could be used for matching. Finally, the third step in the RAND approach would be to develop additional features for that app, which could serve, for example, as a virtual clipboard for the patient to enter in their medications or other important data elements. And this also could be built into current personal health records that as this field emerges where patients are getting their health data on their smartphones, this additional matching capability could be incorporated into those. The third option we looked at was standardizing demographic data. So for example, encouraging EHR developers and healthcare organizations to use the same standards for name or birth date, address, and other data fields that are used for matching but may not be standardized today. This approach has been recommended for years, but hasn't yet been tested. And so we did just that, working with Indiana University and the Reagan Street Institute over there. Reagan Street has a set of databases where they know what the true matches are. They ran a matching algorithm, standardized the data, and reran the algorithm to see what improvements occurred. The findings from that research have not yet been published, but we're hoping they will be published soon. The fourth approach we looked at was referential matching. So this is the use of third-party data sources, for example, information from the post office, that can help validate demographic data. So an example here is if a patient moves from one location to another, they may have filed a change of address form with the Postal Service. The fact that the Postal Service has that, can associate both addresses with the same person, that information can then be used to know that two records that have different addresses may in fact be associated with the same individual. There are some challenges here, though. One of the benefits of this approach is that it is among the highest reported match rates, but there are some limitations. For example, this does not improve matching for pediatric patients who don't have those types of data sources, and it would have the same match rates as other types of matching systems. And patients did have some concerns in the focus groups that we conducted with this approach. Our research led to several near-term opportunities to improve matching. First, there still is confusion as to whether how the government can help advance patient matching given the restriction on funding for a unique identifier, and that should be clarified. Second, there may be an opportunity to improve the verification of data, like Rand suggested, with phone number. Third, there are a lot of privacy concerns and considerations with patient matching and all of the approaches that we examined, and that those should be assessed by government and others. Fourth, referential matching should be examined further, both to independently study the improvements that may be possible through referential matching, and also to address some of the limitations. And fifth, there should be agreement on the standards and data elements used for matching. So standards, for example, the USPS standard for matching, or another standard for address, or another standard for address could be used. And there also may be additional data elements that are already collected by healthcare organizations that could be used for matching. An email address is one of those examples where this data element is already being collected, but could be used more broadly for matching purposes. And this last one is an area where we at Pew intend to continue doing work and encouraging the Office of National Coordinator for Health IT to encourage the industry to advance standardization of these data elements for matching. We also identified several long-term opportunities. One is there's a sense among the experts that we spoke with whom we spoke that there should be a trusted organization on a national scale to help advance patient matching and identify the standards that are needed and encourage organizations to adhere to those standards regardless of what the approach taken, and that there may be an opportunity to have this trusted entity through the Trusted Exchange Framework that ONC is putting together. That Trusted Exchange Framework is a nationwide interoperability plan that is currently in draft form and being developed. Second is there are several options for using smartphones, both the options that we identified with through the RAND research, but certainly other ones as well. And so additional research and pilots are needed to understand how smartphones can be leveraged for matching purposes. And finally, with some of these emerging tools like biometrics, additional research is needed to identify the infrastructure and standards to better leverage biometrics for example, while addressing the privacy and security concerns, essentially to determine if this is possible to be using biometrics while protecting privacy and security, and that is still an outstanding question. And that's an area where we tend to focus on at Pew. So in sum, we see progress. Our research has shown that progress on inter-organization matching is essential for interoperability. Patients want it and expect it to occur, and that's also echoed by the providers that we spoke with. Standards, regardless of the approach taken, are critical, but may be able to help in the near term through standards with demographic data and for the use of emerging technologies like smartphones and biometrics. And ultimately, improving patient matching can improve quality while reducing costs. More information on our research is available at the Pew website. I'm also happy to answer questions both at the end of this call and after this call for those interested. Thank you.
Great. Thanks so much, Ben. Now our next speaker is Zach Hedinger. Again, he's the medical director at MedStar National Center for Human Factors in Healthcare, and he's going to focus a bit more on what hospitals can do and what they've done at his institution. So, Zach, take it away.
Great. Thank you so much for the opportunity to speak with everyone today. I'm going to apologize in advance. I'm about 45 minutes away from a shift, and so I'm in the hospital. Occasionally may hear some overhead pages, so I'm sorry for that. We'll do our best to minimize. So just want to put out some disclosures there in terms of our funding. I haven't accepted any funding from specific device manufacturers around this area or any other conflicts. This is all kind of federal grants and research funding, but I always like to put that up there. The agenda that I would want to cover today is just kind of briefly go over human factors engineering and kind of where our team, multidisciplinary team of cognitive psychologists, clinical researchers, as well as computer scientists kind of approach some of these issues. I want to talk a little bit about a framework on how we like to think about problems and specifically how we're dealing with health IT-based identification errors. And then a few frontline case studies that we've either written about or discussed. And then there's also some literature and solutions that I want to put out there as well. So a little bit about human factors engineering for those of you that aren't familiar with it. It's about designing for human use. And whenever we think about that, there's always this interface between the human and the machine. That means that there's a display and a control as we interact. It really is about optimizing the relationship between technology and the human users. And we need to match the system and the abilities of those users, and making sure that it's data-driven and evidence-based. This is not just kind of your best practice or what do you think might be the best approach. There really is data driving these decisions. And this is the norm in aviation, nuclear energy, as well as the military for many years. And over the last 15 plus years, it's been becoming more and more the norm within the medical healthcare environment. So just, again, always like to give a frame of reference. When we think about this human-machine interface, we all have had the experience of having a shower handle, and especially when you go to a hotel or an unfamiliar bathroom and you go to turn it, and it's not always clear, do you turn the handle to the left, to the right? You've got the H and the C there for hot and cold, but they're kind of off to the side. It's not always clear exactly where you're supposed to turn it. You might have to turn it around a couple of times. So here the interface is speaking to us, the dials there, and then we're trying to manipulate it to understand the impact that it's going to have on our environment here, whether you're going to get a good shower or not. A little bit better design here on this particular handle is that you've got the red and the blue across the top. Kind of gives you a little bit of an idea, and it's hard to see in this picture, but there's a little arrow up there that kind of is indicating which way you're supposed to turn the handle. So a slightly better interface, still not always the easiest thing to navigate. You still end up finding yourself putting your hand out and kind of waiting for the temperature to change in the water based on the display. So again, this human-machine interface, how can we kind of anticipate how people might misinterpret in this case, the shower handle, or in the case of what we're talking about today, the interface and how we interact with it, and try to prevent misidentifications of patients. Okay, so that's just kind of the broad overview of a human factors approach, in that case, shower handles. When we think about healthcare in general, our team has kind of developed this model that we use to approach problems that we call the Integrated Patient Safety Transformational Model, PST. It also stands for Primary, Secondary, and Tertiary Prevention. And in healthcare, we often use this model of primary, secondary, and tertiary prevention around things like cardiovascular disease. So primary prevention example being healthy lifestyle, exercise, not smoking. Secondary prevention is kind of controlling some of those risk factors for cardiovascular disease, such as diabetes, hypertension, high cholesterol. How can we manage those things before someone develops heart disease? And then tertiary prevention is, you've had the heart attack, and we're trying to minimize the impact that has on the patient to prevent things like cardiomyopathies and congestive heart failures and so forth. And so we think about these as in our approach of taking human factors into the environment is that oftentimes healthcare systems think more about that tertiary prevention. We wait for that bad event, that kind of catastrophic event to happen where we start dealing with things. The patient that is misidentified and ends up getting a blood transfusion that was intended for a different patient and then could have some catastrophic outcomes. What can we do to look for the hazards in the system in that kind of pre-hazard period, primary prevention, doing good user-centered design, and implementing best practices from other environments or other healthcare systems, focusing on that secondary prevention of kind of the hazards there, but it's before it's really harmed the patient, kind of anticipating that there are going to be mistakes that are being made. People are going to choose the wrong patient for one reason or another. What can we do to have some safety checks in there before that actually ends up harming the patient? And we know that in the aviation industry that pilots make about 2 mistakes every hour that they're flying, but the systems that they're using, the flight control deck, is designed to anticipate those errors and design them out of the system. And then, of course, that's not to ignore things like adverse event reporting and doing root cause analysis and claims analysis for risk management. Those are all critical pieces, but we also want to make sure that we're paying attention to that primary and secondary prevention areas. The other research that I just want to point out is some work that we did looking at root cause analyses across a large state-reported database as well as kind of individual root cause analysis reports. And this is an article we published in it was 2013, and we looked at all the solutions that all of the healthcare systems were kind of implementing as a result of root cause analysis. And we started thinking about these in terms of this two-dimensional model of effectiveness and sustainability. And oftentimes we, as a healthcare system, might focus on things that are maybe effective in the short term, but not particularly sustainable over time. And there are some things that maybe aren't really going to be effective or sustainable. So things like, let's get risk management involved, and let's have some disciplinary actions and fire the people involved in this kind of name, blame, and shame way of doing things that has unfortunately been the norm in healthcare in the past. I think we're moving away from that in general, but we wanted to start thinking about what's going to be effective and sustainable. What can we do that maybe is helpful, like sending out a memo or email or kind of alerting everyone in the short term might be great for a little while, but it's not going to fix the problem long term. You're going to get staff turnover. Something else is going to pop up, and so people are going to forget about it. We have things like physical environment, forms and paperwork, process changes that are going to be a lot more effective, a bit more sustainable, but eventually you really need to bake things into the institution, to the IT structure. Maybe sometimes the physical plant potentially might need to change, but that's going to take some time to develop. But likely if you're addressing the problem, it's going to be much more sustainable than any of these other solutions like changing forms and paperwork. So that's, again, two kind of models that we use to often approach problems. So in terms of the framework of dealing with misidentifications, it can really happen at any point in time. And Ben did a great job talking about the patient record matching. Oftentimes I think about this in terms of our health information exchange teams that are out there, trying to match records between hospitals, but certainly within healthcare systems, especially as they get bigger and there's lots of different interoperable systems. So for me, as I was kind of thinking about what I wanted to talk about today, I've started thinking about these as issues that might happen in the pre-encounter period, kind of healthcare, a particular healthcare encounter event, things that can happen during the actual encounter, and then things that might happen post-encounter, leading towards these misidentifications. So first, I want to focus on the pre-encounter period. As I said, Ben did a great job kind of going a lot into the record matching piece, but I want to talk a little bit about some interoperability between some of the internal systems. So the first case I want to talk about is junior versus senior. This particular case, patient John Smith Sr., kind of as a de-identified patient here, calls up the primary care doctor for an appointment, and that the administrative team, secretary at the desk, kind of takes the information and then ends up putting the information in under junior. Unfortunately, what that does is it sets up even kind of weeks to months in advance that the wrong chart, the wrong patient is kind of primed into the system. So the physician comes in, they've got their daily schedule, they might be running around between 15-minute appointments, and they go right in, they open up the charts that's in front of them, and especially depending on the way the interface is designed, the junior and senior might be cut off, it might be kind of truncated if the width of the field is cut off, and they end up starting to document on the wrong patient, and as they're talking to the patient and kind of talking about medical problems, hey, I thought you had high blood pressure, and what about that prostate problem you had, and so forth, and all of a sudden the context of what they're seeing in the chart doesn't match up with the conversation or the experience they're having with the patient, and then it eventually gets recognized and gets corrected, and then the correct patient chart is entered. There we have a near miss there, the resilience of the providers catching this, but you could easily imagine that the provider might not catch it, especially if it's someone they're not familiar with, like in the emergency department where you don't really know the patients in advance. It might be very easy to kind of continue on through because of the chart that's placed in front of you. And oftentimes we lose that context in the electronic health record world, whereas maybe senior might have in the old school, days of paper charts, this super thick chart that's got all this information. But when you open up an electronic record, depending, again, on the system and what's displayed in front of you, you might not see that quote-unquote thick chart in front of you that might be one of those visual cues that would help. So in this case, in terms of thinking about solutions, here we identified in this particular case that some of the default fields and column widths contributed. When we start looking at the interoperability between systems, for us in our healthcare system, we have some legacy systems that interact with our EHR, and particularly our registrar teams are actually using a significantly older program that interfaces. And so there I've seen multiple instances where the junior and senior is cut off, or the patient's middle initial is cut off, and then that feeds into the system and then ends up propagating this misidentification so that at the actual time of the encounter, there's a low likelihood that the team is going to catch that there's an error. Another solution that our team has tried to do is reduce the amount of manual patient searches. So trying to reduce the time that you have to search for a patient chart. Are there ways that, again, we can embed the connection between these systems and prevent some of these errors? One thing that we did about 2 or 3 years ago was our Regional Health Information Exchange System, CRISP, was now embedded. So instead of a link where I then have to go search for the patient's information in the background does that searching algorithm matching technique that Ben was talking about. And if there is a high enough degree of match, then the information is displayed within the electronic health record. If there's any concern that there might be a mismatch between records, then they kind of direct you to kind of a patient matching where there's a more manual search based on the criteria that's in the system. So we do have to be cognizant that there can be mismatches in these matching algorithms and account for that and build it into the system. But certainly doing manual searches has a significant risk associated with it as well. The next case we wanted to talk about was John Doe. So we have a 35-year-old male arrives with suspected drug intoxication disorientation. Patient's able to kind of mumble their name and maybe their date of birth, but it really requires some imagination in terms of the interpretation of what the patient is saying. They don't have any ID on them, potentially have been assaulted. At that point, the registration team needs to register them either as a new patient or they potentially, if they search on the information they have, they might kind of make a best guess, which is not really how we want to be doing things. And so then the chart either gets bifurcated, so now the patient who has been in the system has 2 different charts, or they get merged into someone else's chart. And this is always a risk with our trauma patients, non-English speaking patients that might in order to be polite, they might nod, they might agree with it, but not necessarily understand the questions that are being asked, or there might be some misinterpretation there. And then certainly our elderly population that might have some sort of cognitive impairment or potentially substance abuse. And once those records are merged, it becomes very challenging to catch the mistake. The times that I've caught it while I've been in clinical practice have been when the patient starts telling me that, oh yeah, I was just here in the hospital 2 weeks ago, and then I can't find any record of it. And then when we start asking, confirming their information, and we usually find that there was a letter off or a number off in their date of birth somehow along in the process. But again, very tricky to catch those. So solutions that we look for in this particular area are kind of expecting the unexpected, that we know that we're going to have these patients that come in with challenges with their identification, having a good process in place, being able to merge them when necessary. If patients come in in my kind of pre-EHR days, we would have what we called trauma packets. So if a patient came in from a significant trauma and we knew that we weren't going to be able to identify them quickly, we would just go ahead and make them kind of a Jane Doe or John Doe and just get them in the process, and then there was a merging that happened afterwards. And that becomes more difficult with electronic systems, but we need to anticipate those, and our vendors and our healthcare systems need to anticipate a good workflow and process for these patients that we can't identify. As Ben had talked about earlier, biometric scanning is certainly a possibility. There are concerns around that that Ben also touched base on. And then smartphone IDs and so forth, again, he touched on. So these are definitely helpful in those patients where we are having a hard time making that positive identification for a variety of reasons. Next, I want to talk about identifications that happen during the encounter. So one that we've studied a number of times is pick list refresh errors. So if I've got a list of fake names up here, patient names that might be in a selection list, whether it's inpatient or for me in the emergency department. So maybe I intend to order on Edward Smith, and I have my mouse, my cursor right over, and then right at the exact moment that I go to click, I've kind of already made that mental decision to click, the screen refreshes, and in one instance, we've seen the screens will refresh every 60 seconds. So basically every minute there's a chance that this error could happen. It auto-refreshes, Larry Fitzgerald gets added, so then Edward Smith, who I was going to click on, gets moved down one spot, and then Charles Klaus gets pumped underneath of the cursor, and then you click. And this can all happen in milliseconds to the point where you might not even be able to recognize that it happened. And this has definitely led to wrong patient errors within our system that oftentimes go unrecognized. And some research that our team did in the past was focused around wrong patient errors. We did a variety of testing with 46 emergency medicine providers. We had them click through on some simulated settings. On the third one, we created this error where we sent them to the wrong chart, and we looked at how were they able to recover from this. We found that 76% of the time they just continued on ordering the correct test on the wrong patient. We looked at the context of when these errors were getting caught. Only about, again, 11 providers out of the 46 caught the error. And it was while they were entering information on the patient. They were entering their kind of history of present illness. So that has some keys to how we design our systems and how we have users interact, and that kind of making it the Amazon one-click, let's be as efficient as possible and place orders as quickly as possible, might have some safety ramifications that end up preventing us from recovering from these errors that we know are going to happen in the system. Some work by a number of researchers have been around this retract and reorder entry tool, basically trying to identify when a wrong order is placed on a patient, that it's intended on one patient by a provider. They then look for that order to be canceled, and then the same order written on a different patient by the same provider as a kind of a pattern of error that is reproducibly happening. Green and colleagues wrote up a paper where they were looking at the error rates associated with this tool and whether they could improve those. And so they introduced this kind of 2.5-second delay as you were ordering, and then required the user, the physician, to type in the patient's name. And they found that the error rate went from 2 per 1,000 orders down to 1.5 per 1,000 orders. So about a 30% reduction initially, and that was sustained at 25% 2 years out. So a nice kind of effective and sustainable change, significant change. The challenge with that was that they kind of looked into this a little bit further and found that it takes about a little over 4 seconds per every alert that fires, and then if you basically would have to use about 1.5 hours of physician time in order to prevent a single error. Bob Weers wrote an editorial at the same time that then extrapolated out. If we implemented the system across every EHR, across all orders in the system, that's an additional 900,000 hours versus of physician time, which is equivalent of hiring basically 400 physicians to just type in the patient's name, just do a name check. So some significant limitations as we kind of try to scale out some of these solutions down the road. The last area that I wanted to talk about was the post-encounter period. And here was a a particular study that was done by Edelman and colleagues, and they were really interested in studying misidentifications in the neonatal ICU. So if you're not familiar, patients that when they're born and have to stay in the ICU immediately afterwards, that at the time of their birth, a lot of families don't know the patient's, the baby's name, or they're still thinking about it and so forth. So the patients are typically registered in some sort of a standardized manner, so baby boy Smith or baby girl Smith. And one of the concerns was that then you have a neonatal ICU that might have 20, 30 plus patients that all of them have the exact same first name and only differentiated by last name. If you have a common name like Smith, then you all of a sudden start to get concerns. And there are some workarounds that the teams would use, like the last two numbers of the medical record number plus the last name and so forth, but then you have twins, and those numbers seem to can end up causing problems in and of themselves if they're sequential numbers. So they looked at the baseline error rates and found that about there were 117 errors per 100,000 orders, so kind of consistent with what we were seeing in Green's work earlier. In addition, they went in and started doing a slightly different nomenclature for the patients. So they started naming, instead of baby boy, baby girl, they would say Mary's Girl Smith based on the mom's name. And if there were twins or triplets or so forth, then they would add a number to the end of that. And they actually found that that, in addition to doing ID reentry, similar to Green's work, they found that they dropped the error rate by about 50%. The naming convention added a little bit more. I guess the ID reentry was the 49%, and then it went down to 61% when they did both the naming convention and ID reentry. So some interesting work that's been out there, that how can we kind of catch this error, that it wasn't the error the child was named correctly based on the processes, but that processes in and of itself sets them up for a high likelihood of misidentification, during the duration of their stay in the hospital. So, in summary, just wanted to say that we touched base a little bit on human factors engineering and expecting errors and designing around them. Talked a little bit about a couple of these different case scenarios that are out there, that redesigning interfaces, doing good surveillance so that we can kind of capture how often these errors are happening, and then some process preventions that we can use to potentially change the course of our patients that instead of setting them up for errors. So with that being said, I want to thank you all for the opportunity to speak, and I'll hand it back over to Evan.
Great. Thanks so much, Zach, and thanks for the presentation. We're going to move on to the Q&A portion of the webinar now. There's obviously still time to submit your questions using that Q&A button at the bottom of your screen. We have a few in the queue already, so I'm just going to get started, but feel free to keep sending them in as we go along here. Ben, I'm going to start with you. This is more of a look at what the federal government can do, but what steps can ONC, the Office of the National Coordinator for Health IT, take to advance patient matching?
Sure. So ONC, which is, as you know, the federal agency that oversees EHRs, has several policy opportunities where patient matching can be improved, specifically around the standardization of demographic data, both how current demographic data that are used for matching are standardized, and also the addition of other data elements that could be used for patient matching. One of the areas where ONC could help advance these concepts is through the Trusted Exchange Framework, or the policy it has called the U.S. Core Data for Interoperability. For those that don't know, the U.S. CDI, which is currently in draft form, is a set of data elements that ONC is encouraging to be exchanged on patients. It builds off a previous policy to do, and a current one that's currently in practice, on which data elements should be exchanged. And the current policy lists the patient's name and date of birth and a couple other things that could be used for matching purposes. ONC could build off of that by adding additional data elements that are already being collected but may not be regularly used for matching, and to encourage certain standards for at least a subset of those data elements where there is utility in doing so. When the research comes out that we worked on with the Reagan Street Institute and Indiana University, that will hopefully provide additional context on which data elements standardization could be helpful with.
One quick follow-up to that, because you mentioned it in your presentation, but the idea of a unique ID, and obviously, as you mentioned, Congress has sort of limited HHS from sort of doing that. But how much would that help? And I mean, are we sort of past the point of a unique ID sort of being helpful at this point?
Our research indicated that there are other opportunities that that would benefit from focus instead of focusing on a unique patient identifier, which, as you point out, has been restricted. There has been funding restrictions from Congress, and those funding restrictions have been in place for approximately 20 years. Even aside from the political considerations, there are still limitations to the use of numeric unique identifiers, and that's why some of these other approaches that can be used, both standardizing data for the near term, but also looking at some of the emerging technologies like smartphones and like biometrics, is where we've recommended progress to be made.
Mm-hmm. Another question that just came in here, and Zach, I'll start with you on this one, but maybe you can both weigh in. What do you suggest in the event of identity theft? I don't know how much that comes up sort of with these patient matching issues, or if you guys have run into that, but are there any feedback on that?
I think certainly some of the things that Ben talked about would be key in terms of leveraging outside data and matching patients and verifying. Unfortunately, we do have those instances, and I have cared for patients that have purposely misled or made up information because they were worried about the cost of healthcare. And then when they come back for follow-up, we can't find their records, and so it certainly impacts our ability to care for those patients in addition to the legal issues associated with it. So certainly coming up with better ways to match with external data sets and using smartphones and so forth, I think holds a lot of promise. I don't know, Ben, if you have other thoughts.
Yeah, it's certainly, as kind of Zach points out, is a challenge that we've heard has been happening. But it's important to remember when we talk about patient matching writ large and on a nationwide scale, the use cases that we're focused on are those where the patient wants their records to be matched, where care coordination for a patient at their direction, for example, is not occurring at the level where it should be. When records for a patient that wants their records to be matched are only actually successfully done so half the time, that doesn't help support care coordination and quality improvement and patient safety for that individual, and that's why progress needs to be made.
Mm-hmm. Great. Zach, I'm going to send another one your way. What can healthcare systems do to measure patient misidentification if they have limited resources? Probably something that everyone runs into at some point or another.
Sure. There's a good chance that the healthcare systems are already collecting some of this data and might not realize it or haven't had a chance to really optimize around it. So when we oftentimes place in orders on patients and then we either cancel or void them, those are potential rich sources of data for near misses or potential adverse events that can be worth looking into. And I think sometimes that's just kind of seen as, oh, this is just data in the system, we're going to ignore it. But I think that they're incredibly valuable. The other thing that we've been implementing over the last couple of years is looking at session recording of use sessions. So whenever our healthcare staff members log into the EHR, we're able to capture that, store it for 7 days, and then it's deleted for new space to come in. So using those sessions that are recorded and coming up with algorithms to look at them has started to give us some great insights into how these and other errors are happening within the system. So there might be some technology that's already being used for maybe the information services team that might be kind of managing the EHR. There might be a lot of things that are already out there, help desk tickets potentially, and obviously root cause analysis and patient safety event data that's out there that's already being collected, but it takes a little bit of effort to skim through at those different levels. But there's probably information that they can already use that they have.
Ben, I'm going to send a similar question to you. Not just what can hospitals do on limited resources, but I know some of the work that Pew did showed that it was relatively or at least easier to get their match rates up from say 50% to 90% or something like that, but obviously much harder to get those last incremental changes. So I guess I'm wondering, if for hospitals that are at that point and also contending with sort of other priorities, what have you found that they can do to sort of to help that issue?
Thanks. So I think we need to separate a bit between the internal match rates and the external ones. And internally, what we heard from the interviews with executives was that some relatively small changes could make more significant improvements for those organizations where they have relatively low match rates. Whereas for those organizations that are already at the cusp of internal match rates, that it would take a pretty significant paradigm shift to get some of that smaller incremental progress. Some of the approaches that that we've heard anecdotally could help are some of the emerging ones. The use of advanced technologies like biometrics or smartphones or referential matching or some other approaches. The additional challenge between inter-organization matching is where we heard that additional progress is needed across the board. And that's in part because each organization doesn't have full control over the match. By the inherent nature of having to send or receive information from another organization, then the success of that match is also reliant on what that other organization does. So if both sides of the transaction of trying to exchange records are not standardizing data in the same way, well, that could have ramifications. Or if we're not using the same data elements, then that could have ramifications. And each organization only has control over half of that relationship and exchange. And so that's why additional agreement on the standards, implementation on standards, and government involvement to help advance some of these notions is absolutely critical.
Maybe another quick one you can answer, Ben. Has there been any effort to partner with companies that have started this process with large data sources from around the country? So I guess this particular company leverages data from USPS, Social Security, name change, those types of data sets, and has them stored already. Are there any sort of private sector partnerships out there that are already ongoing?
Yeah, we've certainly had many conversations with some of those organizations that do already leverage third-party data and have incorporated their input and perspective into our research findings. But it's important to remember that as Zach was talking about earlier, defining what the match rates are is very difficult. Each healthcare organization defines their match rate in a different way, at least the ones we spoke with. And also, they don't know what they don't know. If they knew which records they aren't matching but should be, then they would have matched them. So there's this lack of a denominator to really figure out what the match rate is for many organizations. And that's why some additional research and examination of approaches that are using some of these third-party data sources would be really helpful and advance the field if there were an independent examination of the relative improvement of using these other data sources for matching.
Yeah, that makes sense. Zach, this one's for you. What can EHR vendors do to reduce patient misidentification? What's kind of their role in that process?
I think a really important collaboration between the vendors and the healthcare systems. Some of our earlier research where we went to a number of EHR vendors and asked them about their usability design practices, talked with some of the vendors, and when we brought up some of these, like the refresh pick list error, some of the engineers had no idea that that was a potential. And they said, oh, well, we could come up with some nice, visualizations or limit the auto refresh. They started coming up with some ideas, but they weren't even aware that that was a potential risk. And so sometimes these things that even if they are brought to the attention of the healthcare systems, those aren't always communicated back to the vendors, or there isn't a good process in place. So I think that having that two-way communication about any usability issues with the electronic health record system is particularly important. And then also being able to share these across vendors, across healthcare systems. So developing things like safety use cases, which we had partnered with Pew recently to develop health IT safety use cases, and those are up on the website that Ben had up earlier. Those types of cases, I think, help point out to both the vendors as well as the healthcare systems that these are potential risks in their system. The only other thing that I would point out is that there are some design practices that we can do to help with patient matching within the electronic health record, choosing the right records. That also can be implemented. Some work that we did with Human-Computer Interaction Lab at University of Maryland, where we looked at the role of patient photos and as well as kind of short pauses around 500 milliseconds used to highlight patient information can help draw the provider's eyes to the right part of the chart and also reduces the risk of misidentification of patients. And there's been a little bit of work around the use of patient photos in some other healthcare systems and research out there as well. So there are some significant steps that the vendors can do, and also kind of promoting based on the research out there, what are the best practices.
Mm-hmm. Looks like we have time for just one more question here, and I'll put it to both of you since you both mentioned it briefly in your presentations. But what are some of the outstanding challenges to biometric use that really need to be resolved before it can be used in healthcare? And Ben, I'll start with you.
Sure. So there are certainly a few different questions. The first is just within each modality. A modality would be the iris scan or a fingerprint or facial scan, things like that. So within each modality, how is the information standardized so that what is recorded from the biometric can be compared across different technologies or used across different vendors? That's one question. Another question is, should the biometric be scanned on the patient's personal device or scanned on a device within the healthcare facility? Another question is around whether actual biometric data should be used or whether it should refer to some other type of identifier, and then that identifier is what's actually exchanged and used between two different organizations for matching. And certainly those are just a handful. There are privacy and security concerns and challenges that would need to be addressed with biometrics and with any infrastructure using biometrics. And the same types of questions are also applicable when multiple modalities are used. So if one facility is using an iris scan, another is using a facial recognition, how can that information be used for matching when it's not the same modality, if at all? So there are some areas, among many others, that we intend to explore.
Great. Zach, anything to add from that perspective?
The only thing I would add to that is that we also, again, for me working in the emergency department, we often have patients that are presenting to us in a traumatic situation, and so that might also limit the use of some of the different technology, depending on if they have a hand injury and then the particular facility is using hand, whether it's fingers or palm prints. Can we still be able to use that? And then is this a patient that's known to the system so that we could have that stored within our EHR and be able to authenticate against that. But if they're a new patient visiting from another area, then you start getting into some of those issues that Ben was just talking about in terms of where's the data stored, how are you able to access it, and the utility of it if it doesn't have a significant patient population. And then challenges, the larger the patient population, the kind of speed and accuracy of the data as well. So still a lot of outstanding questions that are out there.
Yeah, for sure.
But definitely exciting to think that we might be able to kind of answer some of these problems with that among the other technology out there. Yeah,
absolutely. Well, I want to thank everyone for attending this Fierce Markets webinar. And I'd especially like to thank our speakers. We were lucky enough to have two people who know a lot about this issue. And lastly, want to thank Imprivata for sponsoring the webinar today. Like I said earlier, the webinar today has been recorded. You'll be able to access the recording within 24 hours using the same audience link that was sent to you earlier. Thanks again for everybody for joining. Thanks again to our speakers, and look forward to seeing you at future events.